Welcome to today's webinar entitled Risk-Based Funding Pilot, Methodology, Lessons Learned, and Application, organized by the Association of State and Territorial Health Officials. My name is Jennifer Lumpkins. I am the Director of Public Health Preparedness at ASTHO, and I will serve as the facilitator for this call. I would like to thank everyone for joining us today to learn about CDC's Risk-Based Funding Pilot from some of your colleagues. I would also like to thank CDC for sponsoring this webinar. I'd like to go ahead and provide you with a little background on the project before we hear from our presenters. In 2011, CDC launched a one-year risk-based funding pilot to accelerate the development of public health, medical, behavioral health risk identification and reduction models, interventions that are proven to reduce risk, and promising practices that can inform the larger awardee community. This pilot was part of a broader risk-based funding project that is intended to provide additional funding to higher risk jurisdictions. Today's webinar will capture some of the information and knowledge garnered from this risk-based funding pilot. Our panelists will discuss methodology, lessons learned, and potential applications of the jurisdictional risk assessments. I would like to now introduce you to our presenters today. First, we will hear from two representatives from the New Jersey Department of Health, Carl Michaels, who's the coordinator for the preparedness program, and Lawrence Heidenberg, South Region Public Health and Healthcare Emergency Preparedness Coordinator. Then we will hear from Jennifer Griffith, the Assistant Professor and MPH Program Director, Director of Practicum Experiences, and Manager of Program Evaluation at Texas A&M Health Science Center, and Jennifer Kiger, Senior Preparedness Specialist at Harris County Public Health and Environmental Services. Lastly, we will hear from Brandon Dean, the HOLA Community Planning Manager at the LA County Department of Public Health. These presentations will be followed by a Q&A session. So with that, I would like to go ahead and turn it over to Carl Michaels and Lawrence Heidenberg in New Jersey. Carl and Lawrence?
Thank you, Jennifer. This is Carl Michaels. As stated, I'm the coordinator for a preparedness program in New Jersey and also the FEP program manager.
And I'm Larry Heidenberg. I work in the South region doing emergency preparedness and coordination for roughly 7 of our 21 counties.
We can go to the next slide. So as stated, New Jersey is one of the 10 risk-based funded pilot sites. We were funded directly, and what's unique is we actually fall within 2 metropolitan statistical areas, New York City and Philadelphia. In fact, 17 of our 21 counties fall into one of the 2 metropolitan statistical areas, so we're the most densely populated state in the Union. Next.
Both Philadelphia and New York City were funded to take part in this pilot project. However, they took different approaches in how they developed their tools, how they worked their system. This made it most difficult for New Jersey to say we're going all Philadelphia or we're going all New York City, because they were, while the end results would have been the same, the way you get there was totally different. Also, to be honest, they both had resources that we in New Jersey did not have. In New York City, it's a closed system. They have more data that they could use, so they had a very data-driven system that aligned very closely with the Kaiser model. In Philadelphia, they contracted with the Drexel University School of Public Health, and so they had academic support directly. It allowed for more flexibility in more areas where specific data was lacking. So what New Jersey had to do was blend the best of both tools, along with New Jersey's own requirements, to be able to create a statewide hazard and vulnerability assessment. We took the Philadelphia tool and modified it to meet our needs. Part of the challenge is that New Jersey has different data capabilities than probably most states in the Union. We have certain areas where we do not have the authority to require all the data that most states might ultimately have the ability to reach out for. So we partnered with other organizations. One of the key partnerships we had was with the New Jersey State Office of Emergency Management and the New Jersey Office of Homeland Security and Preparedness. These two partners were of great assistance in helping to bring in the more diverse group that we really needed to be able to make this whole project work as well as it truly did. Next slide, please. All right. The big picture for creating this, you have all sorts of capabilities that you already are tracking, the CPGs for the CDC. That helps create a preparedness score, tells you how ready you are for certain things. But there are various, various areas that did need to be worked at. We had to look at the probability of a specific event occurring. We had to look at its impact on public health, on health care, on environmental factors that contribute to health. All of the capabilities, the public health service impact, the community impact, the healthcare impact, and the human impact, all of those contribute to severity. We know that probability times severity is risk, but you have to adjust. You have to adjust not only for how well prepared you are, but you also have to adjust for your vulnerable populations, because sometimes they will be much more affected than the average population and require additional services that you just don't have. We collected what evidence we could, but there are certain areas that are lacking. We admit that. Therefore, we had to use subject matter experts to help us out with this. For the vulnerable populations, though, there were many different categories that could have specific needs so that one vulnerable population would be more affected than the rest. Things like hearing disabilities, vision, ambulatory, cognitive, limited English proficiency. In fact, that's one that can range widely within our 21 counties. One of the examples for that is how English proficiency can vary. We have a lack of English proficiency in one county of 7.9%, while in another county it ranges all the way up to 56%. All of these things do affect how ready you are, how prepared you are, and how bad your risks may be. Because in some areas, certain risks require English proficiency as a key component to get the message out. Others, it's not quite so severe. Next slide, please.
Just hold on there for one moment. Go back. So in the bottom left-hand corner, Larry mentioned CPG. That stands for Capabilities Planning Guide for those that may not be aware. And those are the 15 CDC FEP capabilities there. So each year, every state is required to do capability self-assessments. So those self-assessment scores that are incorporated into the model, and then we adjust our risk score based on those assessments, and the as well as the special population adjustment for at-risk populations as well. Next slide. So here you'll see some of the data that we did have. We used regional planners at the State Department of Health level to gather all of this data. We looked back at 100 years worth of data, and we, as Larry mentioned, we developed essentially our own tool, modifying primarily a combination of both, but mostly Drexel's model. We simplified Drexel's model a bit, and a lot of the credit to our model goes to Dr. Esther Chernak at Drexel and her preparedness team. And then we conducted our first pilot test with Salem County with a group of multidisciplinary stakeholders to get all the kinks out of the process. And then after that, followed up with 2 regional workshops, one in the north part of the state and one in the south. We'll talk more about what took place at those workshops on an upcoming slide. Next. So here you'll see the actual hazards that we looked at. We, as I mentioned, we looked at 100 years worth of data, and then in conjunction with our partners, we came up with these 8 to use for our HVA. We got a lot of the input from our county and local health departments, a lot of input on infrastructure from Office of Emergency Management and county OEMs and existing HVAs. And the Drexel model had more hazards than these 8, but we opted to go with these, and Larry will tell you why.
Yeah. What we found was there were several individual categories that really could be conglomerated into a broad category, one broad category. One of the things is the human mind is best able to deal with information in chunks, with the optimal number of chunks being 7 plus or minus 2. Anything more complicated than that becomes harder to comprehend and retain. By combining hazards, things like tornado, hurricane, winter storm, etc., into severe weather, the information was easier to grasp, while simultaneously the issues, regardless of the original cause, were likely to be substantively similar. Flooding has different consequences than many of these others, and different actions needing to be taken. That's why flooding remained a hazard on its own, separate from all of the rest. Next slide, please. When we conducted these workshops, we brought together subject matter experts from a variety of areas: emergency management, public health, healthcare facilities, the healthcare associations in New Jersey, special and functional needs experts, mental health representatives, emergency medical services, and our own Department of Health. All of our data that we'd previously collected was made available to the participants. These included things like the FEMA declarations that had taken place in New Jersey, New Jersey's distribution of hazard events and economic losses, including county-level data, New Jersey's disability profile from the Census Bureau Fact Finder. We want to plan on repeating this about every 5 years or after a significant event. This allows us to combine hard data when available with subject matter expert opinions that have direct experience with these issues to create the focused answer appropriate to their specific jurisdictions. Unfortunately, data does not speak for itself. Everyone says the data speaks for itself. No, data just lies there. It requires interpretation and understanding. And while we had experience since the HVA had been completed, and we'll talk about this a little later on, we had experience with Hurricane Sandy, or Superstorm Sandy as many called it. Sandy hit many of our counties and, quote unquote, should have affected everything along the coast the same. It didn't. It tells us, as we expected from our work here and from what our HVA showed, that what happens with one county is not going to be exactly the same as another county. We needed to be able to drill down and focus better for this. Next slide, please. Here's a sample of the New Jersey tool. Honestly, I know this may be a little hard to see on here, and I do apologize for that. But all we were looking for was, okay, mark off what is the probability of occurrence: improbable, remote, occasional, probable, or frequent. And we did provide definitions. We looked at how much of an increase over the normal daily baseline in a variety of categories one would expect from one of these events. Part of the difficulty in New Jersey is we have 565 municipalities, and we are truly a home rule form of governance, with a multi-tiered control over emergency medical services, for example, where New Jersey's Department of Health only has direct authority over some of the services. Others are governed by the New Jersey First Aid Council, a non-governmental body. A lot of the data that is available to a more centralized system like New York City, or with the capability to subcontract to a university to gather this data, this information was merely a guide to the subject matter experts in confirming or refuting their own experience and knowledge to arrive at a consensus answer to our questions. One of the keys for this version of the tool, the New Jersey tool, is face-to-face group interaction. It was essential because it allowed the different subject matter experts to discuss and debate. Had we done this in a sent-out survey as opposed to a face-to-face meeting, honestly, we would have had much different answers, and they would probably not have aligned half as well with what we've actually experienced since the HVA has been put together. It just would not have captured it well. Next slide, please.
At the workshop, each of the tables that you saw there were represented by different counties. So a group of multidisciplinary stakeholders within each county. What you see here is the overall state results for the state of New Jersey, with the top planning priority score being pandemic, followed by terrorism, which is CBRN, chemical, biological, radiological, nuclear, and Larry E. Explosives, I'm sorry. And then severe weather, not counting flooding. So they're the overall three, combination of all the counties. Preparedness may be low, severity may be high, or more likely a mix of both. But some important things to remember is you can't always be prepared to prevent, but we can be prepared to respond. And since completion of the HVA, you see that the top three hazards have all been very relevant. In New Jersey, we're dealing with Ebola as one of the five regions, the airport, one of the 5 airports in the country, accepting passengers from West Africa. And then we had a recent case of Lassa fever. We've seen increases in terrorism throughout the U.S., including the nearby Boston Marathon bombings. And severe weather, we were just coming off when we completed this data and completed all the data, finished our these planning priority scores. At the time, we were just coming off of Hurricane Irene, and that was fresh in everyone's mind. Just shortly after, before we even published our HVA report, we were hit with Superstorm Sandy. Major destruction. And even Hurricane Irene, we hadn't seen anything like that in such a long time. So this really made us start to begin to question all of our data. But it wasn't time to do a reassessment when we were in the middle of a recovery. It would have been wrong to bring those partners back. There was far more important things. So we did address this, and we just put that in the narrative in our report. And the suggestion is to complete another HVA assessment process every 5 years or after a major event. So we'll probably repeat our process again sometime in the next 2 years. Next.
Okay, here you can see in graphic imagery how the probability and severity alone distribute out. You can see, for example, a nuclear facility accident would have great severity, but the probability is pretty low. We have flooding and weather events happen very frequently, but they don't have great severity for the most part. Terrorism falls pretty much right in the middle, along with pandemic, as to the likelihood, the probability of its occurrence, and has a much higher severity. These don't tell all of the story, unfortunately. That's why everything has adjustment factors. Next slide, please. As you saw in the slides, a couple of slides ago, we had the we had the state's highest vulnerability and priority planning being the areas of pandemic, terrorism, and severe weather. In Salem County, which was our pilot study, they had different answers. Why? Their greatest hazard was hazmat, followed by pandemic, followed by terrorism. The reason being that Salem County does not align with the states is they have different county-specific hazards. They have a full 10% of the top 100 chemical concerned sites in the state of New Jersey. That's obviously going to affect things more than another county that may not have any industrial or chemical production and very little transportation through the county. Also, Salem County hosts the second largest nuclear generating complex in the nation. They have a very robust preparedness program for it. That's why their planning priority score for nuclear was pretty low. It could happen, certainly, but their preparedness for it is actually pretty darn good. It's one of the 3 highest areas that they were rated for preparedness. These things are pointed out for each individual county, because even those counties that were neither part of the New York City MSA nor the Philadelphia MSA participated and received their answers. We were providing a tool for the entire state, not just what CDC was looking for at the time. One of the key factors that you have to keep in mind when you're using a tool like this is you can come up with the conglomeration answer for the state, but you can't really compare one county to another county when the hazards don't necessarily align, because each county has its own specific problems and focus. Next slide, please.
So just like Salem on the previous slide, one of the nice things about this HVA is that all 21 counties came away with their own HVA and had their own hazards prioritized. Of course, the whole report was shared with all of our county and local stakeholders. And at the local level of 565 municipalities, it could go even lower. So we do encourage municipalities could use the same tool and create their own HVA even at the local level. And we've certainly learned from experience that while all emergencies begin at the local level, a collaborative response can make a difference between life and death. Next slide, please.
Okay. We had a variety of projects that we put in place to work on advancing our overall preparedness. We had an advanced registration system for vaccine administration. We had alternate care sites, long-term care emergency preparedness initiative, mass evacuation, mass gathering preparedness and response, medical needs sheltering, and pandemic planning. All of these areas work on multiple areas of the 15 capabilities that CDC has us look at annually. We're looking to get the most bang for our buck. Even something like the long-term care initiative. That initiative, the benefit of it was not only in preparing for a variety of capabilities, but it was put severely to the test during Hurricane Sandy, and it worked. It helped us be ready to handle things far better than we otherwise would have, and significantly reduced mortality and morbidity that otherwise would have been uncontrolled. Next slide, please.
As you see on this slide, specific capabilities can be linked more closely to certain hazards. So if we look at mass care and sheltering plans, they'll clearly benefit in floods, hazmat incidents, nuclear, and so forth. So the real message here, and this was the findings of our report, that using taking a capabilities approach. So by investing in capabilities, you can mitigate multiple hazards simultaneously. And one of the best outcomes of this whole project for the state and our county partners is that now we have evidence-based driven data in a model that each of those entities can use to justify competitive funding requests when different opportunities come out. And then our last closing slide. For additional information, you could reach either Larry or myself, or take a copy of our full hazard vulnerability assessment, which is posted on the New Jersey Learning Management Network website, and I'm sure that all the slides will be presented with everyone, so you'll have that information. You don't have to copy it down now. And we'll take questions at the end, so thanks again.
Great. Thank you, Carl, and thank you, Lawrence, for that wonderful overview. As a reminder, we will have time for questions at the end of all 3 presentations. So I'd like to go ahead and move right to our second presentation from Jennifer Griffith and Jennifer Kiger in Texas. So Jennifer?
Thank you very much. We appreciate the opportunity to share with you the work we've been doing in Texas together for the last few years. This has been a work across the state of Texas with the Department of State Health Services, the School of Public Health, Harris County, Public Health and Environmental Services, and our CDC-funded Preparedness and Emergency Learning Response Center. Next slide, please. When the CDC RFA came out, we were one of the sites that was looking to get involved with identifying the public health threats and then identifying those strategies and activities that we could use to mitigate those risks and threats. Next slide. As with our colleagues in New Jersey, Texas received 2 of the risk-based funding projects, one in our Health Service Region 2-3, which is in the Dallas-Fort Worth area, and the other in our Health Service Region 6-5 South, which is in our Houston area. Next slide, please. One thing that worked out really nicely in Texas' favor is both of those sites having received the risk-based funding, a decision was made at the state level to combine and collaborate to create a single tool for the state of Texas rather than having multiple tools. And the TXPHRAT, which is the Texas Public Health Risk Assessment Tool, had the developmental objective of expanding a public health-oriented evidence-based tool to meet those CDC requirements as well as our stakeholders' needs. The goal was to have a tool that included impacts on public health, healthcare, and mental health, that measured the positive effect of mitigation efforts on different hazards, was informed by science, and because we were trying to minimize subjectivity of measurement, to provide some scales of measurement that all counties, all 254 counties in the state of Texas could use. Next slide, please. This tool came about rather quickly. We started developing it in October of 2011, and I've been involved with many projects in my career. I have never seen something come together so quickly, and I think that has a lot to do with the development team and the leadership at the state, regional, and local levels within public health. Also brought in our emergency management partners at all levels of the state and local government, as well as Homeland Security, healthcare systems, mental health, and academic partners. The resulting TXPHRAT tool, which Jennifer Kiger will explain in a bit more detail in a moment, provided preloaded data, so it saved the jurisdictions from having to do a lot of digging and research, but also allowed for jurisdictional input and some modifications in case there was information that was held at a local level that wasn't available more broadly. And we also had the ability to leverage multiple funding sources, including our FET dollars, the risk-based funding dollars, and the Preparedness and Emergency Response Learning Center dollars. So what you see in our presentation today is not solely based on the risk-based funding dollars, but a collaborative effort to integrate the activities to reach a common goal across all of those platforms. Next slide, please, and I'll hand it off to Jennifer Kiger.
Thanks, Jennifer. All right, so for the TXPHRAT tool, one of the equations we had was hazard risk score equals the probability times the vulnerability times the critical infrastructure and key resources times impact divided by 10. So for probability, we use frequency-based approach that translates annual frequency to probability for events that are well documented. So the primary sources we used were from Shieldus, US DOT pipeline, and we also used NOAA's National Climatic Data Center database information and NBS data, which the State Health Department uses for disease outbreak and foodborne outbreak frequencies. We also use the funding sources available to jurisdictions for a proxy for probability for terrorism incidents. This is one area of the tool that if the county believed that the probability was off, they were able to go in to the tool and make a change and reference the reason for the change. And then the change showed up in red in the tool to make sure that everyone knew that there was a change made. As for vulnerability, that was taken directly from the Social Vulnerability Index. The CIKR, for the current iteration of the tool, it is actually held constant since it only applied to 36 of the 254 counties within Texas. We're working with the Homeland Security partners to try and make it work for future versions of the tool and applicable to all of the counties within Texas. As far as impact, we looked at the public health impact, healthcare impact, and behavioral health impact, which I'll go into further in the next slides. Next slide. All right, public health impact. We use the following data sources to make this calculation. We utilized students that were getting their MPH to conduct this data research since it was a lot of work. And we calculated it from a harmonic mean for each indicator. So summing all the scores and getting a harmonic mean gave us the number for the public health impact. Next slide. The healthcare impact was utilizing these data sources, and there was a composite score based on cost, relative significance to public health, and the availability of data. We utilized our HBP partners as well to get some of this information that they have and then use it in the tool. Next slide. So for behavioral health impact, this is where we had the least data that we could find in order to pre-populate into the tool. We had these several components that we wanted to include into it. However, we had a hard time finding it for all of the counties. So we utilized our behavioral health experts from Texas Department of State Health Services for some estimations where we couldn't find the actual data. But these were the components that we used for the larger jurisdictions. Next slide. We also calculated the residual risk score. So it was the hazard probability times the severity of consequences divided by mitigation. So the hazard probability we already discussed before, but the severity of consequences, it's population vulnerability times and the health impacts. It factors the population vulnerability and impact on health. It's pre-populated. Mitigation, however, it's a lot of data that is put into the tool by the person or jurisdiction entering the data. The mitigation component includes the Capability Preparedness Index, where we, like New Jersey, use the CDC preparedness capabilities, the 15 capabilities, and we weighted the functions within each capability according to the relevance of the 41 hazards. We had 41 hazards identified and defined for our tool. We also added that to our available resources, where the jurisdictions provided their available resources on a scale from 1 to 4, which 4 is fully in place, on where their level of resources were for each hazard. And then the last one was community resilience, which we agree needs further development, and for this iteration we had it constant at 1 for the computation. So next slide. This is an example of the tool, what it reads, and you read the tool from left to right. So at the left is the probability score in navy and blue, and then you get your social vulnerability index, which is the same number for the county, but every county has a different number, which includes the critical infrastructure and key resources, which you see is held constant at 1, and then the 3 impacts, which gets you to the hazard risk index in red. Then you go into the mitigation pieces, which would have an effect on that hazard risk score into your residual risk index, which is your residual risk index is what a lot of the counties and jurisdictions used to define which hazards they were going to focus on. Next slide. These are some of the outputs that the tool also gave. One of the things that we discussed when developing the tool was the importance of having some type of graphs or easy things to look at for county and city jurisdictions and leadership, so that it was quick and easy and they didn't have to read a lot of analysis. So this one right here is capability gap analysis, where in blue, I don't know if you can see it, is the hazard risk weighted capability goal. The green is the hazard risk capability assessment, and then the red is the gap between the assessment and the goal. So the red is the really crucial part here, where that gap is. So it's, I believe, lined up into the order of biggest gap. So when we're looking at strategic planning, we can look at the areas that there's the biggest gap in capability and try to address those gaps. Next slide. This is another graph which is talking about the resource gaps, and this is where we, each jurisdiction inputted into the tool what types of resources were available for each hazard. And here it shows in blue the hazard score, and in green the resource score in proportion of hazard score. So it can maybe help prioritize what purchases or what activities need to be done in order to help mitigate the hazard. Next slide. So this is the risk assessment results for my county, Harris County, and it may be a little blurry, and I apologize, but here it shows that the top 3 gaps were tornado, hurricane, tropical storm, and biological terrorism communicable. And while none of these were very shocking to us that they were, a top gap, because, we are a coastal jurisdiction in the Houston area, and we do obviously have a lot of hurricanes and tropical storm bill right now. It was good because it did give us some more validity with some external partners on how public health has an impact on these hazards and how we do have a role at the table. So just wanted to give you all that. Next slide. Jennifer Griffith.
All righty. So as Jennifer Kiger mentioned, they had the information to share with various stakeholders, and one of the things that Texas A&M helped with was figuring out ways to communicate the kind of complex tables and graphs that somebody may not have enough time to sit down with to understand if they aren't as familiar with the TXPHRAT tool. So one of the things that we came up with is called the Jurisdictional Snapshot, which gives the top 5 hazards both based on the hazard risk score as well as the residual risk score. And as mentioned, that residual risk score, a lot of our jurisdictions focused on that because it takes into account those mitigation efforts. If they're doing a really good job, as they do in Houston with hurricanes and tropical storms, it may be at the top 3 or top 5 on your hazard risk score, but when you account for the mitigation risk, it may not be in that top 3. It may move down the list. So that's something that became very helpful for moving forward. And we could go to the next slide, please. So this is the Harris County snapshot, and as you can see, there is a lot of things that actually do match up going across on those residual risk scores as well as hazard risk scores. So we're also trying to have a visual way that our partners could leave something, say, with the county judge or the emergency manager, whichever partner they're working with. Like New Jersey, Texas is a home rule state. So being able to communicate some of these complex hazard risk information to different stakeholders is really important. And this also becomes a tool to start the conversation about what are we going to work on. We have funds that we need to do something with to address risk in our jurisdiction. Where should we target? And that led us to our next slide. So we had a number of tools, first being the TXPHRAT, but we also created a number of tools in our partnership over the last few years to help jurisdictions move from that assessment period into planning and development of intervention strategies and mitigation plans, into the implementation of those plans, and even the evaluation of those plans. Next slide, please. One of the tools that was really popular was our intervention strategies and activities document. We culled the literature, culled some of our academic practice partner websites from the old CHIP program as well as the current PEARLS program to identify best practices for various public health interventions related to these 41 hazards and 15 SEP capabilities. And the example you see on your screen is one from Seattle and King County Public Health around text messaging during public health emergencies. And what this tool allowed our jurisdictional partners to do was look at that snapshot document and say, okay, we have a huge capability gap in communication of information to our stakeholders in our community. They could search within this larger 500-page plus document to identify various strategies aligned with that capability, or they could look at their hazards and say, we have high risk for tornadoes. What are some strategies that others have used to address tornadoes? So this tool became really popular as a starting point to think about some of the mitigation activities different jurisdictions would engage in. Next slide, please. In order to help counties and our jurisdictional partners document what they were working on in order to be able to go back and see the changes they made, especially for future iterations of assessment with TXPHRAT, we created a tool to document and report on the activities that they were working on. So this particular template serves as both a planning document as well as a reporting document that local jurisdictions would share with their regional offices as well as the state office and what they had done for the past years. And part of this was getting them to think through some of those measurable outcomes as well as how they align with some of the SEP capabilities and applicable hazards, so that if they had the opportunity to work on something that was a top hazard or a top gap, that they were able to demonstrate that what they had done met with the results of what the TXPHRAT had indicated. Next slide, please. So we've been involved with this project for many years now. Sometimes it feels like 20. I think Jen might agree that we spend a lot of time together working on this, but we enjoy it very much. But we had stakeholders around the table. Like New Jersey, we brought groups of stakeholders in our various regions together, including public health, local health care, law enforcement, emergency management, you name it. If they were at all engaged in public health and preparedness, we had them at the table. But what we started to realize is that we were missing a step with all of these tools. Next slide, please. We had the tools, but we hadn't provided a framework for the overall mitigation planning process. So this past year and a half, we've been working together with the state on the mitigation planning process for the state that integrates the tool that came out of the risk-based funding project, as well as all the planning tools. Next slide, please. The vision of this particular activity is a state of evidence-based preparedness through systematic public health mitigation strategies. And essentially, we just took what we had been doing for the past few years and formalized the process. It's worked out nicely in our favor because we're able to accomplish all of our goals for meeting that vision through the 4 distinct phases of the TXPHRAT or TFRAT mitigation planning process. The assessment phase initiates the process, and that comes from the TXPHRAT, that comes from CPGs, and also what we call strategic mapping in our state. Those results are then used in the planning and development phase and used to inform the mitigation strategies that are carried out in the implementation phase. And in our final phase, evaluation, we look at the effectiveness and impact of public health mitigation strategies that feeds back into our next assessment loop. So we're working to continually improve the process in that regard. Next slide, please. All right, Jen Kiger.
All right, so our last 2 slides are just summary. So for the TXPHRAT, how we utilize it throughout the state is to inform LHD and the state of our top hazards and assist in prioritizing goals and objectives for current and future planning. So we don't necessarily take it word for word from what the tool says. However, we use it as a guide in order to plan for the next 5 years or 3 years in our training plans, exercise plans, or even our strategic plans. We update the TFRAT every 2 years along with the capability assessment. Texas has now made the capabilities assessment required every 2 years and not annually, so that we have more time to make some impacts on our capabilities and hazards. So that's a little change. Next slide. So lessons learned, what went well. The tool is evidence-based. It's informed mostly by actual data, and it's standardized so that we can share it between jurisdictions and reassess annually. Since both Dallas area and Houston area got the funding, it was very useful to utilize that funding and other funding to create this tool that was applicable to the entire state. And it made it very easy for jurisdictions to fill out the tool, since a lot of it was already pre-populated. Also, the collaboration among several agencies, like Jen had mentioned earlier, was really well done, since we were able to get input from different areas with different expertise. And then the buy-in from local, state, and regional partners. Some of the gaps, and some of them we're working on, but the data is insufficient at times. So behavioral health impact scores, there's just not a lot of data in the counties that have smaller populations, and so we're trying to figure out how to address those issues. And then community resilience. It's also difficult to utilize an Excel-based system due to different operating systems and versions of the software. At the very first meeting where this tool was rolled out, there were a lot of issues with different counties and governmental organizations using different versions of Excel, and so when they utilized this Excel tool, they weren't able to open it, and that led to a lot of issues getting started. Resource typing for public health resources would be really useful for the resource availability tab. It's hard to enumerate whether or not you have enough resources for a hazard when people's definitions of what resources are necessary may be different. And then currently our capability assessment doesn't include the hHAP capabilities in there. However, that is something that we're working on looking to improve for future iterations. Next slide. And there's our contact information for myself, Jennifer Kiger, and Jennifer Griffith, and that's all we have. Thank you so much.
Thank you, Jennifer and Jennifer, for sharing your experiences. Just as a reminder, those that have questions will have an opportunity at the end of the call. I'd like to go ahead and move on to our last presentation from Brandon Dean in LA County. So, Brandon?
Thanks, Jennifer. I've got just about 12 slides here. I'll just run the group through. We just want to tell the story from how it played out here in Los Angeles County. There's some similarities, obviously, between New Jersey and Texas, and some slight differences as well. So we call this putting the health into hazard assessment. It's kind of our tagline as we were taking it out into the community. So next slide, please. Here's a brief outline. We'll talk a little bit about the challenges of emergency public health planning, which we're all familiar with, and then talk specifically about the process, the goal, assessing risk, the tool itself, and some of our lessons learned, and then we'll wrap up with what we're doing with this assessment. What was the end goal, and how are we applying it going forward? Next slide, please. So, and I hesitate a little bit to throw this slide up there. Just, I'm sure we're all very familiar with some of these challenges, but I think it's worth mentioning, especially as we consider what it is we're trying to do, both with the risk-based funding and moving the capabilities into the future going forward on what is really health and medical preparedness look like. So there's lots of different hazards. There is no real standard definition of risk. We went out to the CDC at the launch of this, and they brought in some folks, and we distinctly remember one of them putting up a slide and saying, well, here's 5 definitions of risk. You can choose one of these 5, or just go ahead and make up one of your own. And it was clear that there needs to be some standardization around what it is this term means. What is most important? How do different priorities get factored in? And again, where's the health? We saw a lot of things through THIRA, if you're familiar with that process. And THIRA relegates health into just one of 31 capabilities. Obviously, we're somewhat biased, but we feel like that the health is really, if it is not the most important, it should be put at least as a significant priority. Another key concept that we struggled with and that we feel that we have a pretty good understanding now after this process is the difference between all hazards and hazard-specific capability-based approaches. We're believers in both. We think you need both. But as we went through the 60-some-odd different hazards that we developed, we saw that different hazards require different types of plans, different capabilities. And even within the FEP HVP capabilities, for instance, we can look at Ebola versus MERS. Each of them will require capability 11, which is non-pharmaceutical interventions. But how that plays out is different. Different resources are required, different plans, different protocols. And we saw that, and it was borne out in our Ebola experiences of the fall. And then also as a key to our process is the engagement of the community. What does that mean? How do we do it? And what do we do after the assessment is over? How do we continue to build relationships and build bridges to include them as long-term planning partners and not just as another data point in our tool? And obviously these challenges are not unique to LA. They cut across whether you're at a state or whether you're at a local. But we do believe that the complexity compounds for large jurisdictions like ourselves or like a large state. It's interesting to hear New Jersey talk about how dense they are. LA County has 88 cities just within ourselves. So it's somewhat difficult to apply these things, and every jurisdiction is going to have to figure that out for themselves. Next slide, please. Another thing we really wanted to focus in on was that this assessment wasn't just, assessment for the sake of assessment, but there was this higher goal, what we call the eye on the prize, and that the real value is in improved planning and true capability development for prioritized risks. That's really where we saw the value, and it's what we continue to feel like is important as CDC considers adjusting the FEP and the HVP capabilities. We think there's some opportunity to hone both the hazard assessment portion and to really clarify and strengthen the role of both all hazards and hazard-specific planning. And so in order to do that, you need an assessment process and a tool that strongly emphasizes the public health focus on the standard assessment, which really looks at risk times vulnerability. We feel like you need something that's flexible and adaptive for different sized communities and agencies to use, and we built our tool with that in mind. And lastly, we felt that it needs to be able to engage the community in the right way at the right time, and we'll talk more about that in just a couple slides. Next slide, please. So I don't want to spend too much on this, but risk obviously is a ubiquitous term. There is no standard definition, and there's even less standard application. We feel really that it's best understood as a relationship, a complex one like most relationships are, between a community, the hazard or the threat, and the response, both the vulnerabilities and the available resources. And that influenced our formula. We all kind of have standard formulas, but we put all of those pieces into our formula. Obviously, it's an inherent challenge to balance both the probability versus the health impacts, or what we call the consequences. And we really feel like that whatever risk formula a jurisdiction chooses, it just needs to be reflective of their own values and their own data inputs and things that they have. So we built that into the tool as well. Next slide, please. So here's a brief little roadmap of our assessment process. I thought about chopping it into different pictures of the tool, but I thought I'd keep it simple for the purpose of this webinar today. Our tool, like pretty much everyone else, pulled pieces from the Kaiser tool, and we also pulled pieces from UCLA's what's called the Hazard Risk Assessment instrument, and it's now been moved up to the University of Utah. So we plucked different pieces that we thought were applicable, and then we put our own spin on it. So in the upper left there, you see that we started off with 62 hazards. The tool itself includes each of these hazards. We wrote up a brief description, and then we wanted to standardize the impact. So for each scenario, there is a standardized either cases or casualties, hospitalizations, and mortalities. I think we'd all understand and agree that we're really comparing apples to oranges, but we thought that we could maybe try to make it a little bit clearer so we could start to compare different types of apples to different types of apples, if that metaphor makes sense. So we took these 62 hazards. We learned quickly that that's way too many to include, to roll out to the community. Our eyes start to glaze over. And so we wanted to really chop that list in half, or make an attempt to do that. And so we ran it through our own steering committee, which was composed of our MSA, our Metropolitan Statistical Areas. So that included the counties of Los Angeles and Orange, as well as the cities of Long Beach and Pasadena. And we assessed the probability of each of those different scenarios, as well as the health severity. So not just the consequences, but how would this really, truly impact the health and medical systems in our various jurisdictions. And so that gave us a top 36. And then that list, and I should point out that all these hazards are broken into 4 main kind of buckets. So there's a biological, there's a nuclear/radiological, there is a natural, and then there is also what we call an infrastructure. So utilities, freeways going down, things like that, that has its own separate classification. So each of these 36 we then brought out, and through a series of engagements, we did 10 large meetings with the community. They ran from August 2012 to March 2013, and they were spread out between the counties of Los Angeles and Orange, so that's a rather large piece of real estate that we bounced around. We were able to get over 75 agencies, different agencies, to participate, and we had over 220 participants. So at each one of those different assessments, we would present the different scenarios and then ask for the public health folks to assess the public health system impact. We asked the healthcare and medical community to assess the healthcare system impact assessment. And then we asked the mental and behavioral health system professionals to assess each scenario based off of the mental and behavioral health impacts. So that provided, those variables provided our vulnerabilities, if you will, that side of the equation. And then in order to understand that relationship better between risk, we also asked them to identify and assess what resources they had, again, scenario specific, that could be brought to bear to mitigate or offset some of the vulnerabilities or health consequences. And then we broke the resource assessment into two, and that's kind of that peach color, those two boxes there. The responder agencies, so anyone that was affiliated with the government, their scores were cataloged in one way, and then any of the numerous community agencies, so Red Cross, we had several faith-based organizations, we had food banks, we had the emergency response groups like CERTs and things like that. We even had like a neighborhood watch team show up at one of our assessments. So all of their resources we've been under the community agency. So taken in total, these were all the various variables for our risk formula. We put them in to our blender and then poured out what we called our prioritized planning lists. So that kind of completes the circle. Next slide, please. And again, there's our hazard assessment process. The results or the scores, I'm jumping in down to the middle there, were put into the risk formula. And then we found so many tricky areas, and I'm sure New Jersey and Texas would agree. It was kind of like we'd come up to a new part of our path, and then we realized we needed some more assistance to really hone in the data. So we hired a Homeland Security operations researcher, a mathematician, to help us come up with a workable way to weight the different variables. It is, at the end of the day, really all about the math. And if we were trying to ensure that probability wouldn't pull or skew the results one way or the other, we also wanted to assure that the impacts wouldn't pull or skew the data one way or the other as well. So we wanted to be sensitive both to the kind of ongoing emergencies. In California, for instance, fires. We have fires every single year. But the health consequences of a fire are really not that significant when you compare it to a flu event or an infectious disease or a rat or a TIM event. So we wanted to be able to balance both the normal, if I can use that term, emergencies, as well as what we call the black swan events. So those events that you hope that never happen or exist, but when they do, the impacts are such that they completely overwhelm your systems. So the researcher was great. She ran us through a series of tests, and all of this is laid out in our guidebook. But we were able to come up with some different weights that reflected our own jurisdictional values. And then those weights helped determine the different value sets or planning priorities for LA County, for Orange County, for the cities of Long Beach and Pasadena, respectively. And so you can see that third bullet, the final results determine the risk priorities by agency and by jurisdiction. And this process established a hook for future community engagement under what we call whole community planning, which is really advanced hazard-specific planning that really seeks and engages the whole of community in developing the capability-based plans for each of the different prioritized hazards. Next slide, please. Just a couple more slides here. This is a picture of our tool. It's a standalone Excel tool. As I mentioned, there's 62 scenario-based hazards broken up into the bio, the chem, the rad, the natural, and technological. The tool gives you automatic rankings and prioritizations. It obviously focuses on its seeded community involvement. And then an early version of this tool was used by the state of California, which is a really, really large state, obviously. And they have taken it in slightly different areas. It's more from a grants management perspective and less from a capabilities-based / threat-specific-based planning approach. But we are quite proud. This tool is simple, it's flexible, and it's relatively easily adapted for other agencies, whether it be we've had churches use it and cities use it. The state of California has used it. We've also had others out here in the West, other states have approached us and asked for the tool. Some of them have been able to apply it for their own processes as well. Next slide, please. So some of the lessons learned from our assessment, we're big believers that you've got to engage early, upstream, and throughout the process with your stakeholders, be they governmental or quasi-governmental, first responders, or community faith-based agencies. Tell them why you are there and where you're going. Everyone that we would go out to, they'd say, this is great. We're so happy to provide input. What are you going to do with it? How is this going to make my community or my agency better prepared for these awful things that you're presenting to us? And we really discovered that if you walk them through where you're going, if you give them a vision and empower them to participate in that, that they are very eager to provide lots of input and lots of help. And we're finding that as we build out these hazard-specific plans now. Another point is use existing networks and resources. Expand as you're able. Be clear. Make it real. Most communities have no idea the difference between an anthrax event and a smallpox event or a flu. Frankly, I don't think they necessarily even really care. I think their primary, secondary, and tertiary focus is really going to be how does this impact my people, my community, my organization. So as much as you can make it specific and list out the different impacts, be they social, behavioral, economic, or health related, the better your process can be. And then also just listen. Listen to the responses. Be prepared to explain your agency's role and function, and address misconceptions. And if you just forgive a quick anecdote, we were working with a homeless advocacy housing group, talking to them about what their plans would be in an emergent disease like a SARS or a MERS, and they gave us some very pointed criticisms about how that in day-to-day we're not really interested in where their folks are sleeping, but we would be interested in making sure that they have access to quarantine services and resources of the like. And you have to be prepared to respond to those type of questions and concerns, because these are real communities. They have real needs, and they're going to be really impacted in these events. Next slide. I have just two more. So so what? The assessment results to advance planning for specific hazards. And the next slide. So what we've done is we have, you can see there's our top 20 results from our assessment. And I'm sure that with some slight tweaking, many of us on the call have similar lists. And again, a list is just a list. It's really important what you do with it. So we broke these lists into what we call hazard suites. And you can see the 6 of them there: bio, chem, system infrastructure. We put a bin for climate change. That is a hot topic right now in Southern California. There's a natural suite and then a radiological suite. And what we didn't want is for our leaders particularly, but also our partners, to see us as saying, okay, in the next 5 years we're going to spin off 20 plans. We wanted them to see that there are some consistencies and some similarities across the different suites, not necessarily between the hazards, but by suites, but that we would take those on each individually where the different capabilities crossed over through this 5-year response plan development process that we call whole community planning. So when we started it about 6 months after we wrapped up our assessment process, and we took the top 20 list to our director, our departmental director, and you can see number 7 is emergent disease, and he said, well, this is all well and good. I appreciate the map and the effort, but I'm mostly concerned that we don't have an emergent disease plan. So I want to move emergent disease up, and I want you to do that one first, and then I want to take care of anthrax next. So that's what we're doing. In 2014, we developed, for the first time ever, a hazard-specific emergency response plan, and we organized it around the different FEP, HPP capabilities, and FEMA's emergency support functions. It's a nice plan. It comes in about 120 pages, and it was very helpful as we went into Ebola, and then we were able to develop an Ebola annex off of that plan. and we have associated playbooks and things like that that support these documents. But you can see there's our calendar. This year we have a rather large full-scale anthrax exercise in November, so we're developing a tip-to-tail anthrax response plan. And next year in 2016, we hope to take on rad and nuke and chem and so on for the remainder up through 2018. Next slide. And this is my last slide. This is what whole community planning is. It's a yearly planning cycle. Again, hazard-specific plan development. What are the specific risks and the vulnerabilities, and how do we mitigate those? Capability-specific focused. Each plan has a general CONOPS, concept of operations, and specific courses of action. We're finding that the CONOPS is a great document to take back to the communities that we engaged with on the hazard assessment. It provides a nice picture of, big picture, without getting lost in the details and the weeds. What is it we're trying to do, and where's the help that we need, and how can they help us? Again, the community engagement is so critical, and that's about it. Next slide. And this is just the listing of our tools. These are all free, obviously. There's that link, that first link will take you directly to the tool and the supporting guide. There's a planning guide that we developed. It's not very long, about 15 pages. And then also a link to Journal of Public Health Management and Practice. We were able to get an article published on our process, which outlines some more of the details if you're interested in some of the math and things. And then there's the contact info for both myself and Dee Bagwell, who is our Director of Policy and Planning. And with that, I'll say thank you and turn it back over.
Great. Thank you so much, Brandon, for that very informative presentation. All of our speakers provided a lot of information, and I'm sure some of you have a lot of questions. So I would like to open it up to the group in a minute. Before we do that, though, I'd like for you to take a moment to answer the poll question that should be up on your screen. Due to time constraints, the presentations you heard today were just brief overviews of a topic that could be explored at much greater depth. So CDC and ASTHO are trying to get an idea if folks would be interested in joining a follow-up webinar or presentation that takes a deeper dive into some of the details of the risk-based funding pilot. So please take a minute to answer the question that you see up on your screen. And we'll just pause. All right. Well, thank you for those who responded to the poll, and we will take that into consideration for future webinars and presentations. Now, with the help of our operator, I would like to turn to the audience for any questions or comments for our speakers.
Ladies and gentlemen, if you would like to ask a question, you may do so by pressing *1 on your telephone keypad. Again, that's *1. And there are no audio questions at this time. Oh, you do have your first question from the line of Mikey Scullard.
It's Mickey Scullard. Hi, I'm from Minnesota. And I have a question. These were all great. But the title was risk-based funding. So I'm wondering if you're using this to determine funding somehow. This is something we're struggling with, how we create a funding formula for distribution of the FEP funds. And this would be to any of you.
This is Carl in New Jersey. So the funding came from a pilot project from 5 years ago, so we were only funded for 1 year. It may have been continued for a short period of time. But I think now that the requirement for an HVA is in every FEP cooperative agreement. So, I mean, utilizing some of these tools is the key. As far as a formula for funding your locals, I could tell you what we do. We use a population-based county formula, but I'm not sure if that's your exact question.
Well, what I'm wondering is if you use the assessment information that you are generating with these tools and using it to calculate funding levels then based on risk somehow.
We have not done that yet, but it's an interesting, very interesting question.
A follow-up with that, if I may. It's Larry, also from New Jersey. While the state health department has not done so as of yet. Some of our coalitions at the regional level have been looking more at, okay, justify, we have X amount of dollars to spend on regional projects. Justify to us an evidence-based need so that we can choose which projects we do and do not fund. And that has been going on at certain lower levels. So it's not an impossibility. And things like this tool do help make the case for, yes, we obviously have a need for dealing with the impact of flooding in this area, and this project will help in that way, etc.
This is Jennifer Griffith at Texas A&M. I can't speak to the state's funding formula, but I can share some anecdotal experience that a couple of the jurisdictional partners used the results from the HBRA and their TXPHRAT to actually write grants and show evidence for why they were requesting the funds, and that has been helpful in securing funds outside of the normal funding stream.
And your next question comes from the line of Dee Bagwell.
Hey, Jennifer and Lindsay. I just wanted to thank you both for this opportunity, and Brandon for doing such a great job on this. And I wanted to ask you, and unfortunately I guess CDC could not be on the call, but I'm wondering about the next version of the capabilities document that would come up for the next 5-year cooperative agreement, and the potential for some of us who worked on the risk-based project informing kind of the next steps of how this assessment might find its way into that capabilities document in a meaningful, more codified way. I know when they released it, we only had a couple of places that it was mentioned in the capabilities document, and think there's real opportunity for using what we all have done, which is moved beyond what the capabilities document had us do, and really had it inform our planning and work going forward. So I wonder if there's an opportunity for doing that, if you've all been approached, or if it might be something the group could help work on.
Thanks, Dee. This is Jennifer, and I'll go ahead and take a stab at that. So we have not heard anything as of yet, but this is the opportunity for anything that would be in the next iteration for the next 5-year cooperative agreement to have those conversations. What I do know is that Chris Cosmos and others will be having a conversation at the upcoming DPHP annual meeting in Glendale, Arizona. So I think that will also be an opportunity to bring that up to them as they start shaping the next 5 years. So this is definitely something to put in front of them sooner rather than later, because I think you make an excellent point. So I appreciate that. Thank you.
And your next question comes from the line of Mike Harriman.
Yeah, hi, this is Mike Harriman from Oregon. My question is to the two ladies in Texas. I noticed one of your categories was CIKR, and you had a scale of 1 to 2, and you mentioned only 26 of the counties. The data that you got, could you tell me the source of the data, and was it CIKR in general, or was it public health and, healthcare side of the house, like ambulatory centers, long-term care facilities, hospitals, EMS, things like that, or was it just very generic from the source? And thank you for the presentation.
This is Jennifer, and yes, the data was not just the public health and healthcare data that we had received from them. We had worked with the Homeland Security partners in Texas to get that. I know a lot of it is confidential, so that was some of our issues, as well as using those numbers and kind of exposing their information. But yes, it was only applicable to 36 of the 254 counties.
Got it. Thank you very much.
Uh-huh.
Please hold for your next question. I do apologize. Please hold for your next question. And you have no more audio questions at this time.
Great, thank you. There actually were 2 questions on the chat, and these were actually both for for Carl and Lauren. So the first question is on human impact. Was impact calculated for each hazard?
Yes, as the tool was used, every single hazard had the same questions asked, but each individual hazard ended up with different responses for each category, with the exception, of course, of the CPG. Those remained constant because that was where we were at the time. But all of the impacts were individualized to the specific hazard.
Great. Ashraf, does that answer your question? While we're waiting, there was one other question on the chat, and it said, what is the scale for the priority scores? And this is, again, is to Carl and Lawrence.
The priority score was an open-ended, if you're talking about, I shouldn't assume, but if you're talking about the statewide planning priority scores, it was an open-ended number. It was, each one is relative to the others. So the highest score is your strongest area that requires attention, and so on. Because of all of the factors here and all of the things that either added to or subtracted from it being a priority, it didn't have a specific range gate. It was, these are the numbers once it got calculated out, and that gave you the end product. And just as our statewide scores ranged from 4.57 up through 18.81, individual counties had a much higher or occasionally lower number for their individual results because it does vary so greatly.
Great, thank you. We'll go ahead and just check to see if there's any further questions.
Again, to ask an audio question, press star 1 on your telephone keypad. That's star 1. And there are no more audio questions at this time.
Great. Well, if there are no further questions, it looks like we can wrap this up today. Again, I want to thank you for your time and for your thoughtful questions, as well as to our presenters. If you would like a copy of the PowerPoint, or if you would like to request any of the resources or tools mentioned today, please contact Lindsay Laverty at LLOVERDE@ASTHO.org. Again, that's LLOVERDE at ASTHO, ASTHO.org. Thank you and have a great afternoon. So this does conclude today's webinar.